Radhe Radhe to all, and I hope everybody is doing perfectly fine. So, today, continuing our series on rare histological diagnosis of the specimen which I get in my lab and I report the histology. So, today, what I thought would be discussing another interesting case which I got while grossing and then seeing the microscopy. So, see, this is just a statement which comes to our mind, that is omental or gastrointestinal pathology. What could be the cause of death in 24-year-old female? So when this term comes 24-year-old female, this age category, we never think of something malignant, right? First thing what comes to our mind is usually a benign etiology. So let's see what was the cause of death in this 24-year-old female. So moving with the history, this was a case of a 24-year-old female patient, as I've already told you, and what she complained of, pain abdomen. Off and on for this last 3 months she was having it, and for last 2 days the severity had increased. She also presented with abdominal distension, was not able to pass platters, and pallor was there in the patient. In fact, initial by hemoglobin when she was admitted was 6.8. It came down to 2.2 upon subsequent admission. TLC was also less, 1600, platelet 57,000, so it comes out to be pancytopenia. Patient also had low potassium level. X-ray showed gas under the diaphragm, and USG, that is ultrasound, showed small bowel perforation. So all these things she was having for the last 2 days, means in a severe condition, right? But this, just keep in mind the duration. For last 3 months, she is having this kind of off and on vague symptoms. And she was also, one important point was she was cachexic. Loss of weight was very severe in her. And when we saw the CECT finding, so bowel findings, the main two pathology was there in peritoneal and bowel finding. So bowel finding, it showed diffuse dilatation of small bowel loops which involved your jejunum and ileum. Then diffuse intramural thickening was noted at terminal ileum and obviously at other portion of small ileum, a small bowel. Then mild clumping of small bowel loops were also noted in central abdomen. Large bowel loop appeared collapsed, secondary to upstream obstruction. So overall these signs were of small bowel obstruction. And coming to the peritoneal and mesentery finding of CECT, the patient had gross ascites, multiple air foci within the peritoneal cavity suggestive of small bowel perforation. So she also presented with obstruction, perforation, peritoneal thickening, and there was also omental nodularity or omental caking. So this is important because in CECT, when you go back and see, omental caking is usually seen in your few conditions like malignancy, tuberculosis, infectious condition also can this. So this case is overall, it's a deceptive condition until unless we see the biopsy. So clinically and seeing the severe condition and the radiological finding, it's coming out to be like something, it could be malignant also. So we don't know, still we don't know what is the cause of these kind of CECT finding, the omental caking. So what we got on gross was excised portion of intestine with multiple perforation. So query omental necrosis was the presumptive diagnosis that the surgeon had given to us. So we received, when we do the grossing, we received portion of intestine. I had shown you the picture initially, 25 into 8 centimeter. External surface showed perforated areas and it appeared smooth. Lumen showed loss of rugae at places with vegetative matter inside. No visible mass or growth was seen in the specimen. So coming to microscopy, we gave multiple sections and few sections showed the preserved, we can see the intestinal mucosa, and the submucosa is showing your edema, then your congested blood vessels, dilated blood vessels. Now comes the important finding. When we got sections from submucosa and serosal surface that showed extensive, actually these sections I took from the superficial, that mass, the metal caking which was shown on CECT. So we took sections from here, there. So here you are not able to appreciate much of intestinal mucosa. So intestinal mucosa which I showed you, that showed intestinal mucosa, then mucosa, serosa and mucosa, submucosa and subserosa, that showed your variably dilated blood vessels, intestinal mucosa. Here we are not able to appreciate mucosa, but what we are saying is extensive necrosis of the acro. These all are extensive necrosis, loss of all the preserved structure. Here also what we are seeing, first diagram you can appreciate, this is a well formed granuloma we can see here, and beautiful multinucleated Langerhans type of giant cell, which is we call as a horse horseshoe shaped cell. So here we can appreciate it very beautifully. And one section, intestinal mucosa was not showing, but the serosal end we got this granuloma. So attached to this environmental portion, so we got this, the mesentery and all. जहाँ से भी section लिया वहाँ पे भी हमें we got this multinucleated giant cells. Now the main mental kicking portion, from there you can see sheets of adipocytes, bundles of fibroblasts surrounded by your dense fibrocollagenous stroma, and what you can see is beautiful granulomas interspersed in between. Here you can see 3, 4, and this is a hyper, which another section area which is showing you caseation, necrosis. In surrounding we can see the fibroadipose tissue. So here is a hyper view of a granuloma. We can see scattered epithelioid cells here, and AFB stain I did here, it came out to be positive. And then here it is another section which is showing you your granuloma and surrounded by all the necrotic area, blood vessels, fibroadipose tissue. So impression what we can give here is necrotizing granulomatous pathology. Possibility of omental or intestinal tuberculosis is suggested. And still we need ancillary gene expert, other Judging stain for AFB that we did that came out to be positive. So all those ancillary investigations are required to label it as omental or intestinal tuberculosis. So clinical and radiological, along with that we require clinical and radiological correlations. Just to remember few points. Tuberculosis, as we all know, it's a chronic condition, granulomatous condition, usually caused by Mycobacterium tuberculum. The TB primarily affects your lung, correct? But it may affect any other organ that we know as extrapulmonary. So extrapulmonary site, most common is your lymphatic system. We get extrapulmonary lymph nodes here in the cervical region. Patient come with matted lymph nodes. So that is also a presentation of tuberculosis, extrapulmonary tuberculosis. Another extrapulmonary site is your pleura. Then what are the condition? Main predisposing factor are your socioeconomic condition, malnutrition, chronic disease, or any kind of immunodeficiency. So all those can present to us, present in the patient. So novel tuberculosis, it's a rare condition, account for less than 1% of tuberculosis cases, and mode of dissemination is usually lymphatic, hematogenous, and direct invasion from adjacent tissue can also occur in extrapulmonary TB. How the patient present to you? Normal TB findings, fever, weight loss, abdominal pain, especially abdominal distension, then abdominal mass, night sweats. Our patient had abdominal distension, CECT showed perforation. So these are symptoms of your omental tuberculosis. Weight loss was very significant in our patient. So histologically it is very important because we have to rule out malignancy, and considering the age of the patient also, 24 years is very unlikely to have a malignant, but yes, we cannot rule out malignancy until unless we see the histology. So we have to go through the detailed histological evaluation. So what we got was presence of caseous necrosis with granuloma in histology and positive. Usually, this is the general finding which you need to know. Positive culture of tuberculosis from the tissue. So these are definitive criteria for omental tuberculosis. So we got caseous necrosis, we got granuloma with giant Langerhans type of giant cells, and AFB stain was also positive. And beautiful thing about this disease is that it responds to treatment with anti-tubercular drug, and that supports the diagnosis. Patients का symptoms जो होते हैं get resolved once the anti-tubercular therapy is given to the patient. So medical management is a treatment of choice for this omental TB. 6 months regime, that is with the known ATT drugs, you know it, rifampicin, isoniazid, pyrazinamide, ethambutol. So these are the treatment of choice for your omental TB, like your pulmonary TB. But in rare cases like in R, so it was a chronic neglected case. So here what happens, surgery is needed when complications of a mental TB has occurred, like your intestinal obstruction. We saw in our case, CT findings showed it, intestinal perforation and intra-omental abscess. So all these three complications were seen in our patient. Intestinal obstruction भी है, perforation भी है, intra-omental abscess भी है. So all those things were there. So just to conclude, so this is actually Tuberculosis, this is basically a omental TB, especially when we talk about, say, extrapulmonary manifestations are very common in TB. So tuberculosis also patient often present too, but we are talking about omental TB. So that is a rare entity which can be misdiagnosed as GI malignancy because the presentation, clinical presentation is such. Then you have to rule out that by taking history, you have to go into the detailed investigation, go for ancillary investigations to confirm that whether TB is there or not. So here plays important role of laboratory, radiological, microscopic and histopathological, finding the gold standard you can say to establish the diagnosis in this kind of omental mass or omental caking when you get these kind of specimen. So obviously medical, had the patient presented earlier, medical management would have been the treatment of choice for omental TB. Surgery is needed only when complications occur in extrapulmonary TB. So our patient landed up in surgery, and to add to the word, she succumbed to her illness because there was multiple perforation. Maybe she went into sepsis or not. That the clinical condition we don't know, but yes, she succumbed to the illness after the gross specimen, and we reported. We tried to get the history. The patient was no more. So this complication. So see, so initial, the main crux of the story is that when you have these kind of symptoms like abdominal pain, weight loss, severe weight loss in 24 years of age, do go for detailed investigations. Do approach your physician and get your test done. So that this kind of disease can be stopped or reverted back at the initial stage rather than creating these kind of all the complications of obstruction, perforation and a formation of your abscess. So thank you so much for your patient hearing. Kindly like, subscribe and share my YouTube channel Patho with MK. Have a great day.